there's a pot of money going specifically for an infectious disease that has the potential to spread to high-income countries. And this then fragments the health systems. And Nigeria is trying to do something about that now by setting up the sector-wide approach, trying to funnel all of the monies through a central coordinating mechanism so that funding and resources go to the greatest areas of need. It's 1 year in for the current administration, and I just wondered if you had some thoughts on on the applicability of a swap in the context of global health and how resources flow, and how you think Nigeria is able to streamline the processes. Like
when African leaders were asking the colonial exploiters to leave, one of the mistakes, I think, was that we were more interested in them leaving than us figuring out what we wanted after they left. And very often what happened is that the people who were asking them to leave just became them. And that kind of, they became their proxies, And when you look at the history of many African countries, including Nigeria, that is what it is. That we kick them out, but we replace them with ourselves. And I feel very similarly about what you were describing in terms of funds coming. It's one thing to want the funds to be given differently, for the relationship between us and those giving the funds to be different, and for the reasons for which they are giving the funds to be different. It's another thing for us to be very clear in our minds about what we really want. Because if we're not clear, that money will get into that middle space. Okay, now they're giving it differently, but are we going to use it differently? And to what purposes? To what end? And who gets to decide that? I see the wisdom of that kind of central coordinating thing. Frankly, for me, in Nigeria, I've learned to lower my expectations a lot. Otherwise, my heart will be broken into many pieces. So I think for me, I just want to see something happen. Yeah. I often made this joke when I was in Nigeria, when I was at MPHCDA, right? And when this will sound counterintuitive, when my bosses at the time will say things like, this money keep coming in different pockets and different channels, it's fragmenting things, it's fragmented, it's all of these things. And I would make this analogy that, if you have a roof that is leaking, right, in like 30 places, it doesn't matter to me where you start to plug the holes. Maybe after you plug 20, I can then say, okay, be strategic now. But when it's leaking in 30 places, just start anywhere. Just show me that you can actually plug the hole, and then we can have a debate about, okay, which ones to strategically prioritize. I feel like in my mind, and I'll be wrong, but in my mind, I feel like we're not even at the place where I want to be saying, do this. Just do something. Like, do it. And then, if I see that we can do it, then we can then have a proper debate on, okay, so let's talk strategy now. And I know again this sounds a bit counterintuitive, but when you look, it makes sense on paper, it makes sense in theory, but I want to see it work. In public health and global health, we talk a lot about evidence and things like that. And again, a counterintuitive thing I would say is that it's often a cliche when we say that we're not thinking. And this is what I mean. That in most places where things have worked, in most instances where things have worked, right? Whether it's the UK again in 1948, it's 48, building the NHS, right? Or whether it's Medicare, Medicaid in the US, whether it's the health and care systems across, especially Northern Europe, they didn't need anyone giving them evidence that it's good to do that. You got to it. You did the stuff. And I often joke that if the NHS had been evaluated in 1951, it would likely have looked like a failure. Right? So again, for me, it's start doing something, and then when we see that we can do something, that we can learn, and then we can strategize.